from there, I started to explore airway stuff. I started just reading and gobbling up information, reading and podcasts and taking coursework and studying oral myofunctional therapy. And it's become very eye-opening to me about how many of our patients are silently suffering from airway obstructive issues. It's not just one thing. It's not just correcting the occlusion that becomes the solution for a patient like this. 50% of dental hygienists said the reason why they made a job change is because they wanted to explore a better work environment.
Good evening, everyone, and welcome. I am Lauren Gueits, and I am alongside my co-host, Brittny Murphy, for this special Airway Health Solutions conversation, really focusing on the dental hygienist. Near and dear to my heart is the valuable role of RDHs in screening for airway health with the fabulous, magnificent Katrina Sanders. So welcome, Katrina. Welcome, Brittny. I'm really, really excited about this conversation. I always feel that the hygienists are the heartbeat of the practice. The acronym I always use for RDH is really delivering healthcare. And I am just so thrilled to have you here, Katrina, along with Brittny, to just really kind of roll up our sleeves and dive into how important the dental hygienist is in this airway health movement. So Katrina, I would just love to hear from you. We decided earlier that we're not going to go and read a formal bio because there's just so much to unpack here, uncover. And I would just love to hear from you how you got into Airway, and if you want to backtrack a little bit and just explain who you are and lead into that, that would be cool too.
Yeah, that's so, well, first of all, thank you for that amazing introduction. Okay. The fabulous, the magnificent Katrina Sanders. Like, I need to have you travel with me and always introduce me.
And then I'll like throw down the mat. We'll have
exactly. Yes, exactly. Get the marching band out, throw some glitter. Thank you so much. And it's such an honor to be here. And hello, friends joining us today. It's such a treat to be here. So thank you. I am a dental hygienist. So the opportunity to share tonight about the role that dental hygienists currently are playing and can explore playing in the airway space, I think is such an amazing, yummy, juicy topic. So I'm so grateful to be here. I've been practicing for about 18 years as a dental hygienist. So I graduated from hygiene school in 2007. And at that time, and I don't know if things have changed, but at that time when I graduated, dental hygienists did not learn about airway. Mm-hmm. We didn't learn about changes in tethered oral tissues. We didn't learn. I knew what tori was. I knew that it was a part of had a neck exam, but I didn't understand what role it played in airway. And I certainly wasn't well prepared or set up to have these kinds of conversations with my patients. And I think, like most dental hygienists, it isn't until you experience a CE course that really stretches you outside of the typical Prophy, SRP, perio maintenance, learning about fluoride CE, that really starts to challenge your thought process around what is my role in the practice. And so I had gone to some coursework. I'd seen some, we have an oral myofunctional therapist here in the state of Arizona who does coursework. And I started to hear about the role that tethered oral tissues play on really basic things like struggling to latch during breastfeeding and the kind of snowballing, cascade of events that happen if you don't correct this, and bedwetting and ADHD and all of these things. And I had a typical moment like most hygienists do when you learn this for the first time. And this was, well over a decade ago. I had this mind-blowing moment of like, this is incredible. This content is how come more people do not know about this? And how many moms are losing their minds over their child experiencing, bedwetting, delayed thumb sucking, non-nutritive habits that these children are experiencing. And who's going to be the one to talk to mom about this? Do the pediatricians know about this? Do the lactation specialists know about who's going to talk to mom about this? And so I had some working knowledge of airway stuff. Then in 2018, my mom had been having some airway management stuff. She had been seeing an ear, nose, and throat specialist. And I remember seeing her at my grandfather's funeral, and her breathing was very labored. And I remember saying to my family, like, something isn't right. Mom shouldn't be breathing this way. But I'm the dramatic one in the family. And so everyone was like, oh, Katrina, calm down. Mom's fine. It's not a big deal. Well, about 6 weeks later, she woke up in the morning and she was struggling to breathe. And she asked my father to take her to her ENT. So mom went into the ENT. The ENT did a scope down her throat and found some scar tissue down there. And I guess that was normal. They had been just kind of actively monitoring the scar tissue in mom's throat. And so the ENT said, this is normal for you. I don't know, it's a little enlarged today. So here's a prescription for a Z-Pak. Take this. We'll see you back in 2 weeks. So mom and dad went to the grocery store, got the script filled, came back to the house, and my mom collapsed on the kitchen floor and was without oxygen for a little over 10 minutes while my dad performed CPR on her. They transported her to a hospital in northern Wisconsin where it was determined that she didn't have a heart attack. She didn't have a pulmonary embolism, no stroke, that the cause of her collapse was that the scar tissue in her throat came up and occluded her airway. And although the doctors did everything that they could to manage her condition, we ended up losing her. And that was a real sobering moment for me. I had never treated my mom. My mom and dad lived in northern Wisconsin. I never practiced in my home state. I lived down here in Arizona. So I never treated my mom. I didn't know I knew she was going in every 3 months to the dentist. So I'm just going to assume she was coming in for perio maintenance appointments. I'm going to assume that her hygienist probably did the bare minimum of spot probing, scaling the localized 4mm probing depths, cleaning underneath that bridge because she had a bridge that she struggled to keep clean. And that was kind of it. Alongside the fact that she had been managed by an ENT, I think a lot of us in the dental space will assume, oh, a medical person is watching your stuff. And so it's really easy for us to kind of remove ourselves from the conversation. And I'll tell you, I give anything in the whole wide world for my mom's dental hygienist to have had a working knowledge of, Linda, this isn't right. Linda, you've got GERD, you've got cardiovascular issues, you're a diabetic patient, you have insomnia, you sleep with multiple pillows. You know what I'm saying? Like, Linda, this isn't right. Your pulse ox is concerningly low. You have high blood pressure. You know, none of these things were actively discussed with my mom. And so my mom trusted the one doctor who was kind of managing that a little bit. And I'll tell you, having a moment like that for me, watching my father suffer with that loss and what that was for my family and knowing how needless it was. My mom died at 62 years old, was just really hard. And it was very easy to first feel very angry at the ENT for missing that. And then even more so, I became angry with myself because I didn't know this airway stuff. It didn't directly impact me. I didn't learn about it in school, so it didn't seem like it was that important. And my doctor certainly wasn't pushing me to get this training about this. So unless I was going to do something to empower myself to learn about this, I was just going to be like my mom's hygienist in northern Wisconsin who just supervised my mother's suffering. And so I think about that, and from there, I started to explore airway stuff. I started just reading and gobbling up information, reading and podcasts and taking coursework and studying oral myofunctional therapy and learning about all of the things that are available to us when it comes to learning about, understanding, screening for, talking to our patients, the various kinds of providers that are there to help empower and support our patients, the network of providers that are there that are well versed in how to manage and mitigate these diseases. And it's become very eye-opening to me about how many of our patients are silently suffering from airway obstructive issues at a very mild level. These are my female patients who are getting garbage sleep and they're blaming it on other things because turns out women love to do that. We love to blame all the stuff on other things. And then we go about our day. We sensationalize here in the United States the concept of over caffeinating ourselves, having our morning, afternoon, and evening Starbucks. And so, at a minimum, these are people who have, mild airway issues. And, for those of us who have dove into the airway space, we know that mild sleep apnea still doesn't mean the patient is receiving a CPAP or a BPAP machine. So if we in dentistry don't acknowledge our role, number one, being well positioned to see what's going on down our patient's airway. Hygienists, we stare down that airway for 30, 45, 60, 90 minutes that we're treating our patients. So we're staring down that airway. We get that comprehensive health history. We learn about our patients. We know, my mom scheduled her perio maintenance appointments around her nap time. Like, what 62-year-old woman just has to schedule things around her naps unless she's a poor sleeper? I mean, it was so glaringly obvious. Cleaning out her medications when she died, it was so obvious. It was all there. It was Las Vegas flashing lights, and nobody did anything, including me. So thank you for letting me digress in such a complex
I love
story.
the honesty. I love the vulnerability, and I'm so sorry for your loss and your family's loss. But there's something I do want to focus on is that we can empower ourselves as professionals. And I think that kudos to you for doing that, for taking this and empowering yourself, not only to learn for yourself and your patients, but then to carry it forward to everyone on this call. And kudos to everyone on this call. I wanted to thank you for joining us tonight and taking the time out to empower yourself. That's really what we're doing, because Katrina and I, before Brittny joined us, we were having a chance to talk, and we were actually saying how we both actually love clinical hygiene, and it never got old because we were really empowering ourselves every day to really get to root cause and to really make a difference in patients' lives. So to all those hygienists who are doing clinical hygiene, empower yourselves, learn more. You're going to really enjoy learning about airway and making a true difference. And Brittny took it all the way up to even become a myofunctional therapist and made a different career out of it, really focusing on that. So what I'm really excited about tonight is that you don't have to be a myofunctional therapist. You don't have to be an airway dentist. And you are enough as a dental hygienist to be a really viable part of this team and this movement to save lives. And it sounds a little extreme, but it is, I really believe that that's what we're doing, saving lives every day. So again, Katrina, thank you for sharing your story. We're so thrilled to have you here. We're looking forward to learning from you. I do have a couple of just housekeeping items that I would like to share. First, before I do that, I want to see who's with us tonight. So why don't we go ahead and take the poll and see who's joining us as far as dentists, pediatric dentists, myofunctional therapists. I'm curious to see. I know we heavily promoted this to hygienists, so they'll definitely win this evening. But I'm curious to see if anyone else was curious about the role of the hygienist. So we're almost there. Okay, well, it looks like we have 80% RDHs representing tonight. So thank you so much. And thank you for the dentists and the orthodontists. I think we have two orthodontists, myofunctional therapists, 20. And if there's others, you can put it in the Q&A. I don't think our chat is featured to the public, but thank you everyone again for joining us. We're thrilled to have you here. And just a couple of housekeeping items now and some exciting things to share is that the views presented are the opinions of our speaker and are not necessarily affiliated with Lauren Gueits and Associates, Airway Health Solutions. The following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. And we're actually thrilled to offer tonight a free Intro to Myo course, which is actually valued about $3,000. So we're really happy. And it seems like it always goes, Brittny, right, to the person who like needs it the most and was like, I don't know. So stay tuned. You have to be in it to win it. I'm always so curious at the fate of this and what that brings. So we're really happy to do that. And we're also excited to offer a flash sale to our attendees with up to $500 in savings later this evening, but you have to be live and present to do that. All right, did I miss? Oh, our CE. So if you want to have CE, you need to be in attendance, and there's no codes, no surveys, no nothing. It's just your attendance from Zoom. We will automatically email that to you in about 7 business days. All right, well, I'm so excited to roll up our sleeves. Brittny, I know we were talking back and forth. Is there anything that you want to chime in before we kind of go into Katrina's? I know you've had Katrina on, I believe, as a guest, and you've had more time with Katrina than I did. So why don't you maybe share a little bit about, from your perspective, having her here this evening?
Yeah, so we actually haven't gone to our episode yet. It's going to be, I think, the middle of June we're scheduled. But Katrina, just thank you so much for coming on and for sharing that incredible heartfelt, story, and just put the emotion, like you could see the raw emotion on your face. And I just really appreciate you sharing that message, because I'm sure that it's hit home with more than a few attendees that are on tonight. I know it hits home for me, and losing my father at a young age too. So just thank you. And I'm so excited to connect with you more and learn more from you. So I'm just happy to be here.
All right, and here is the magnificent, fabulous, let me thank you, Katrina Sanders.
Oh man, I love that. Thank you so much for that amazing introduction, friends. It is an honor to be here. And tonight, my hope is to just give a little bit of an over the balcony view about the opportunity for dental hygienists to take an active role in screening for airway conditions. So I'm going to begin the early portion of tonight going over some of the things that you are probably already looking at. But I want you to kind of augment the way you might be looking at some of those things. I'm also going to challenge you to consider that there might be other opportunities for you to integrate other kinds of screening modalities into this. Before I start, I wanted to, I saw this really terrific program. I was up in, where was I? Edmonton, Canada last week. I was presenting up there, and one of our colleagues, a dental hygienist up there, presented this really terrific deck that talked about dental hygienists and the challenges that we're seeing in the workforce right now. Even in Canada, they're seeing issues where there are a lot of opportunities for hygienists and not a lot of hygienists to fulfill those opportunities. And I wanted to share this because this, I think, is what makes a dialogue like this so poignant. There was a survey that was done in 2024 that surveyed dental hygienists who left their job and went to another position. And in the survey, they asked, what was the number one reason why you left your job or why you changed your job to look for something different? And, it's amazing when we think about, kind of the dialogue that's out there, the scuttle about what dental hygienists truly want when it comes to job satisfaction or what they want that attracts them to an office. I think the easy assumption is, I went to the thing that was better pay. Well, only 27% of hygienists said that better pay was the reason why they made a job change. In fact, the highest percentage, over 50% of dental hygienists said the reason why they made a job change is because they wanted to explore a better work environment, and particularly one that encouraged and supported their professional endeavors. So, to the hygienists who are tuning in this evening, thank you for being here. And to the doctors, the chiropractors, the orthodontists, those of you who are on this evening, please know that your participation, you hosting and facilitating dialogues that help empower hygienists and remind us of the critical work that we do, creates and maintains a working environment where we feel like we are a part of that collaboration. And I'll just speak for myself. I don't know about other hygienists, so I'd love to see some hearts show up in the chat box if y'all agree. But I think most hygienists want to be a part of the story. We want to collaborate. We want to talk about it. We want to be seen as a respected team member whose opine matters when it comes to seeing these modalities. So I hope that, I love seeing all those hearts. So that is a huge aspect of job satisfaction for us, and being able to have an opportunity to have these dialogue pieces, I think, is what just creates such a round robin, amazing opportunity for us to be more than a prophy princess, right? So we're going to look at some things that we will commonly see with our patients, things like just the posture alone of our patients. So you look at these things, right? You bring your patient back from the front desk and, Joe, and you bring Joe back. Maybe don't say it like that. Joe, come on back, right? But you bring Joe back, and right out the gate, the posture of your patient can tell you a lot about potential kinks in that airway. I want you to think about the airway like a hose. And so a patient who has really nice, terrific posture, how many of our patients actually sit like this? Probably none. Most of us are sitting up in our chairs right now as we're looking at this slide. But think about the patients, your older patients who are kind of tipped forward. And think about the weight of what that head is going to bear onto the spine, and subsequently how that could provide early kinks in the airway. So early on, you're looking at the posture of your patient, and your patient's posture can also be a determining factor of things like potential oral malocclusion. So Brittny and our OMTs out there are obsessed with looking at these things, right? Looking skeletally at our patients, whether it is a retruded class 2 or a massive mandible in that class 3 occlusion, and looking at how everything really kind of connects. When you see a receded or retruded class 2, as you can see here skeletally, know that it's not just one thing. It's not just correcting the occlusion that becomes the solution for a patient like this. Lauren said it a zillion times tonight, and I love it. We have to get back to the root cause. What is the root cause? What caused this patient to remain in a class 2 occlusion? How did the jaw develop, or rather poorly develop, that creates a scenario where we have a patient that is in a retruded class 2 situation? So if we put this patient into bands and brackets and break their jaw and move it forward and all of those things, unfortunately, if we do not get to the root cause of what happens, we run the risk of, number one, not truly treating the patient's airway, and number two, regression. So most of us, I'm a millennial, albeit I'm the oldest of the millennials, but I'm an elder millennial. So I'm the millennial that my mom brought me into the orthodontist. I had a lot of crowding. My orthodontist at that time, shut your ears, everybody. My orthodontist told my mom to have my first premolars extracted so that I would be ready for ortho. And my mom signed the consent form. My goodness, if I could go back in time. So I had my first premolars extracted for ortho. I had a class 2 occlusion. I, had palatal expansion, and I'm currently an eccentric class 1 occlusion. However, like most 14-year-olds that have their bands and brackets removed, did I wear my retainer religiously like I should have? No. And so what do we typically see? The rubber bands in our mouth, these are our tethered oral tissues. If we don't address what's going on with these tethered oral tissues, can cause us to regress in some of our occlusal issues. So when we look at patients that present with malocclusion, and specifically skeletally driven malocclusion, early on, we should be thinking, we need to figure out what's going on in this case, and referral to an orthodontist who fully understands the complexity of airway. And I want to be very careful about that, because we do have orthodontists. And I'm going to make an assumption that the orthodontists who are here tonight, curious about the conversation of airway, are active orthodontists who understand that what we do when it comes to the repositioning of that mandible and opening up that airway for the patient is one step of maybe multiple steps in that patient's journey for success. So early on, we're just looking at the patient, and I will tell you, so often we're so focused, hygienists, on putting all the information in our computer that our backs are to the patient and we've got our keyboard and we're updating the health history and we're kind of yelling over our shoulder that any changes to your health history, and we're putting the information in, that I think we miss taking a step back and actually looking at our patient. Look at your patient. Look if they've got that long face, the Napoleon Dynamite face. The lips are parted. They can't even gently close those lips. Do they have giant bags under their eyes? What is the color of their skin? Are their eyes bloodshot? What is going on? Let's actually look at our patients. So early on, before we even begin doing oral assessments, there are so many things that we can see with our patients. One other thing before we actually dive and look in the mouth that I do implore you to consider is capturing a pulse ox on your patients. I don't mean to say that this is a perfect strategy, but my goodness, I'd give anything in the whole wide world for my mother's dental hygienist to have captured a pulse ox on her, because my assumption would be that she probably would have captured a very low pulse ox. So your pulse ox score is the concentration of oxygen that is saturating your blood as it's circulating through your body. A pulse oximeter, by the way, I think you can get on Amazon for like less than $30. So this is a very easy peasy piece of equipment. And after my mom died, I brought this to my doctors, and overnight, every operatory had a pulse ox, piece of equipment. So you take this, it's super non-invasive, slap it on the patient's finger. Most of us have had this done at our primary care physician or a women's annual exam. You pop this on, and then it gives you a percentage readout. Normal oxygen levels will be 95% or above. That's going to be ideal. If the patient is under 95%, that doesn't necessarily mean it's bad. We do know that some individuals that have cardiovascular disease or sleep apnea might be slightly lower than that. But I will say, if there are no other causative things, patients got a clean health history and their pulse ox is a 93%, I'm going to be a bit concerned. The antenna's going up, and I'm a little bit weary of what's going on in this case. That pulse ox is a terrific indicator because you can also capture the patient's baseline pulse ox when they come in, and you can watch changes in that patient's pulse ox over a spectrum of time. Hygienists, we see patients every 3, 4, or 6 months for multiple years. These are patients that are long-term patients of our practice. So now you can actively track changes in that patient's baseline. So I'll do an example. I am an avid jazzerciser. And so when I take my pulse ox is consistently 98 or 99%. Like, I got a pretty darn good pulse ox thanks to jazzercise. This is not sponsored by jazzercise, by the way. But doing a lot of high intensity cardio, that pulse ox will be a pretty good, healthy percentage. So if I'm consistently at 98 or 99 and I come in and I'm a 95, the next time I come in, that should also be just a slight area of concern where we're going to ask a few more questions, and we want to make sure that we really dive into this case. This could be an early indicator that there's a problem with the airway. We're not pulling in oxygen the way we want to. Now, this is where my homegirl Brittny really spends her time. As an oral myofunctional therapist, they spend a lot of time looking at some of the key indicators of tethered oral tissues. And these are oftentimes focused in the pediatric world, and I do believe that this is where it should begin. This conversation should begin with pediatrics. But is there a whole population or subset of patients that did not have these managed when they were children and now they're adults and they're trying to manage these? Of course. So a very good indicator early on in a pediatric case could be things like open mouth breathing. People love getting those pictures of their newborns with their little mouths just like gaped open, and oh, how cute. Look at this little pumpkin. Close their little lips. They have to be closed. We don't want them breathing through their mouth. Kiddo having difficulty sleeping through the night. I don't know. I was told that like bruxism when teeth are coming in is normal. Not necessarily. So we want to be looking at that as an indicator. Airway obstruction in general. So if the pediatric case is an asthmatic, for example, where airway inflammation or obstruction is going to be an issue, we want to make sure that we're actively screening for potential tethered oral tissues. Kiddos that are picky eaters, particularly, I had a good friend of mine, her name is Lucy. Lucy had an open bite. And we would go out to dinner and she would never order the sandwich off the menu. Why? Because she could never actually bite into the sandwich. So you start to see that picky eaters, some kids just want chicken nuggets and fettuccine Alfredo, and they never grow out of that, like my 40-year-old husband. However, in some cases, those picky eaters are just kiddos that are really trying to adapt to what's going on with their occlusion. Inefficient chewing patterns as well. So as we're watching that masticatory process, they should be effectively chewing their food. And if they're having problems chewing their food is sticking to different areas on the facial surfaces of their teeth. Maybe that means that the tongue cannot effectively clear, or their tethered oral tissues are not allowing for effective clearing. Messy eaters is another good example, as well as drooling. So poor oral control. Kiddos having things like GERD, that's going to be a challenge. Prolonged habits, so thumb sucking. Turns out thumb sucking is going to elevate the risk of things like a vaulted palate. And when that vaulted palate occurs, that now means that the mouth is occupying the airway space. So we aren't just concerned about palatal expansion, we're concerned about the fact that we have limited airway. Prolonged habits could be things like aggressive use of a pacifier beyond 12 months. It could even be oral fixation, things like chewing the string of their hoodie, things like that. And then even listening for atypical speech sounds. So distortion of speeches where kids are not able to say their L's, their R's, their sound. All of these require appropriate movement of the tongue to be able to effectively pronounce these. And oftentimes, when there is a challenge where there is distortion of speech, not always, but oftentimes, these kiddos are referred to a speech pathologist. And speech pathologists can do a great job of going through speech exercises, but not necessarily fully understanding the role that tethered oral tissues can play in speech modalities. So recognizing that, tongue ties and maxillary labial frontal pulls and things like that that are abhorrent and not well managed are going to be areas of concern. And we see the ramifications of that. I mean, this is certainly one of those extreme cases, but you can see that retruded mandible. You can see the flaring of the maxilla. You can see even crowding continue to occur in these areas. So if we don't correct these parafunctional issues as the skull is developing, it elevates the risk for the sequelae of things like mouth breathing, snoring, and pediatric obstructive sleep disorders, which can elevate the risk or complications of things like problematic behavior, hyperactivity, problems in school, emotional issues. So looking at the entirety of the case and getting report of things that oftentimes our patients do share. Mom will say things like, I cannot get them to stop using that pacifier. I can't get them to stop sucking their thumb. Mom is including you in the story. And so you're seeing this unfold. You could ask things like, how are we doing in school? Have we noticed a change in our behavioral patterns? When you see an ADHD medication on that health history, the antenna should go up. We should be looking around. Because yes, we can see a lot of potential complications with tethered oral tissues. Then we look at other findings or other modalities. So it is important to know that a significant portion of obstruction of the airway will occur in areas that we dentistry are articulating or screening within. So about 90% of cases of airway obstructive disorders, that obstruction is going to occur or rather begin around the tongue, soft palate, and tissues of the mouth. So this is where we need to look at other kinds of identifiers that could contribute to the patient experiencing an airway issue. And hygienists, we do screen for a lot of these things. We talked about malocclusion already, but we're going to look at things like the patient's neck circumference, tonsillar relationships, or even Mallampati score. So the neck circumference is kind of an interesting one. I already say if you're trying to get that lead collar around the patient's neck to be able to take x-rays, and we all have patients like this where the neck is so thick that you're trying to get those flaps closed and you can't. So you're like, oh, whatever, we'll just leave it there. And then of course it's so heavy, it like drips down as you're taking radiographs on that patient. If you can't get those flaps to close, that is a decent indicator the patient has a significant neck circumference. So I don't mean to say that you're going to, get out your tape measure and measure the patient's neck. There are some practices that do that. If you don't have a tape measure and you don't want to do that, that's a good way early on to just go, you might have a thicker neck circumference. But it is also important to note that highly fit individuals can have heavily muscular necks. So think about like your bodybuilders that have very thick muscle in their necks. That can also, muscle is quite strong and it can kind of pinch off that airway. And now we're even looking at individuals that have very thin necks. Some of our, very thin female patients, I tend to find they're the ones that also have a thin biotype. So they're quite prone to recession as well. Don't take my word for it. That's just a random observation. But these very thin women will come in with very thin necks. And sometimes that'll mean that they'll have a limited or narrowed airway as well. One of the other things that we can look for is your Mallampati score. So again, none of these are perfect. I had a doctor who does sedation say, do you tell hygienists to look for Mallampati score? And I said, yes, I do. And he said, well, you can't use that to diagnose sleep apnea. And I said, well, of course you can't. You can't use any of these things to diagnose sleep apnea. However, when you see these identifiers, the patient opens up, you take a look down their airway. If you can see down that patient's airway quite well in a class 1 or even a class 2 where the base of the tongue comes up to the tip of the uvula, perhaps you're all right. But if you're trying to approximate down into that oropharyngeal area and maybe you only see the base of the uvula, or in the case of a class 4, you can't see that oropharyngeal area at all. You can't see the base of the uvula. You're seeing scalloping of the tongue beginning to occur. These advanced Mallampati scores, although certainly not a perfect way and certainly not the only way that we diagnose airway issues, but certainly is an indicator that this particular patient may in fact have an airway issue. I want to talk about tonsils for a second. And this is kind of a heated discussion. I didn't see any ENTs in the survey, Lauren, so I'm hoping that I don't offend anybody with what I'm about to say. But I mentioned that I'm a millennial. So I'm the older millennials that played with Tamagotchis and wore jelly shoes and had a big crush on Jonathan Taylor Thomas. I was also in the generation of millennials where it seemed like every other week in second grade, someone was out for the week. Why? Because Mark Lindley had his tonsils taken out, and so he's just hanging out at home having great popsicles for the next couple of days, right? So it was quite common practice when I was younger for my cohort to experience tonsillectomy and adenoid removal. That is not necessarily a commonality anymore. And there are all different kinds of opinions as to why that is the case. The most popular opinion is that medical insurance got involved and said, wait a second, we're not just going to write you a blank check to do tonsillectomies anymore. We need some cause. Why are you having these tonsillectomies done? And ENTs started to kind of dial it back a little bit, maybe not perform these procedures as readily. But there are some good signs, stages, or symptoms, even in our young people, that can indicate that enlargement of the tonsils and or adenoids could be a contributory factor as well. So a kiddo who's snoring or pauses in breathing during sleep is certainly an individual who has some kind of an airway issue. Enlargement of those tonsils could be a contributory factor. Breathing through the mouth during sleep and certainly during the day when there's awareness, that's an issue. Strained breathing, so hearing or any kind of noisy breathing whatsoever, that's going to be an area of concern. Restless, waking up frequently, or bedwetting. That's an issue. The bedwetting piece is an issue with the pituitary gland. The pituitary gland releases all different kinds of hormones to help regulate. And when that pituitary gland does not release vasopressin, the body is not able to store water. And that's where we start to see bedwetting or peeing throughout the night. Unusual sleep pattern, as you can see here, where the knees are kind of tucked in, and the kiddo kind of does that to try to open up their airway. Frequent colds, frequent sinus issues, trouble swallowing, which could be a vagus nerve issue as well, and then hot potato speech. So hot potato speech sounds like someone is holding a hot potato in their mouth. So it's kind of that tonsillar sound. And I'll tell you, once you hear it in somebody, my husband and I had a plumber over at the house the other day, and I was like, do you hear the hot potato speech? Do you hear that? And I just wanted to be like, sir, you need to have your tonsils taken out, because you could hear that hot potato speech. Again, we want to take a look at the different kinds of observations of the tonsils. Some patients have these kind of large lobulated tonsils in the back. This is, of course, a grown adult, as you can see via the facial hair. That should have been a good giveaway. And so these enlarged tonsils, I don't necessarily mean that they're going to create major airway issues, but in comparison to someone who's got a narrow neck, for example, you can see in both scenarios narrowing of that airway, whether it be from a narrowed neck or from relatively large tonsils. These are issues that could contribute to airway complications down the road. And this is a case, this is a millennial as well. This is a case of an individual who probably should have had their tonsils removed as a child and did not. And so we may start to see a lot of those cases start to pop up. Finally, I had mentioned that we do, in fact, look at things like malocclusion. So things like crossbite. Crossbite can certainly create or accelerate potential issues. And when adenoid enlargement occurs, sometimes adenoid enlargement can contribute to a crossbite. I do want to call out all of my data is in small font down at the bottom of the slide. So I promise I'm not making any of this up, but like, how cool would it be if I actually did make this up? We also look at things like open bite. We know that various kinds of patterns like thumb sucking, etc., can accelerate the issues associated with an open bite, forcing that mouth open into that open mouth posture. But managing this kind of a complication is going to require a multimodal approach, because if we don't, we do run into issues of obstruction of that nasal area. And we know that an open bite and oftentimes vaulted palate kind of move in tandem together. So again, when we don't see that wide movement of the maxilla, we can oftentimes see that high arched or V shape to that palate. So that upward growth that occurs in a vaulting situation is what will likely impede, that nasal cavity. Finally, I had mentioned tori and exostoses before. And again, I think when we were in hygiene school, we learned about this, right, friends? We learned about what tori are, what exostoses are, and we see these, by the way, in perio all the time. And it always blows my mind. As a periodontal hygienist, these patients don't have good alveolar bone, but they have these giant lobules of bone. And so we know that tori, the size particularly of mandibular tori, can create complications of airway and positioning of the tongue. My gosh, when you have tori that meet in the center like this, where the heck does the tongue move? And so that can create obstructive issues as well. Tori on the palate like this can certainly create obstructions of where that tongue rests in a natural tongue rest posture on the maxilla. So taking a look at a lot of these identifiers is a really critical next step. I want to kind of conclude with some of the things that patients could report. And I want to share this because when I look at this list and I think about my mom, and my mom was always a bad sleeper. My mom, experienced migraine headaches all the time. My mom did not sleep for long periods of time. My mom had daytime tiredness. She would fall asleep. When I turned 15 and I got my permit, my mom would fall asleep in the passenger seat while we were driving. So there are a lot of good identifiers that an individual has an airway issue and that airway issue is impacting the quality of their sleep. So again, these are some identifiers to look for in mild, moderate, and severe cases of apnea. So the patient struggling to fall asleep, noticing increased movement, restless leg syndrome, or different kinds of limb movements, excessive daytime sleepiness. And there are scales that you can administer to your patients to say, how likely would it be that you would fall asleep doing these activities? And it's things like reading a book, sitting in Katrina Sanders' lecture, typical things that a person should be awake for. And so you can utilize a lot of that information to even evaluate how sleepy your patient is. That's called the Epworth Sleepiness Study. Daytime tiredness, fatigue and dizziness. Irritability is a big one. It turns out if people don't sleep well, eat well, and poop well, they are extremely grouchy. That's not just like a child thing. That's like a human thing. That's a very shared experience that we have. So that irritability is a good identifier. Haphazard sleeping patterns. So patients that are very sporadic with how they sleep. And I'll say this lovingly as a speaker who travels in and out of cities and countries erratically. My sleep pattern is haphazard. That's not because of an airway or sleep disorder. That's because of my work. So we want to make sure that we get to the etiology of it for our patients. Short duration, making frequent errors, lack of concentration at work, irregular breathing patterns, noisy breathing. When the patient's breathing through their nose, you can hear some whistling. You should not hear that. Experiencing headaches, you should wake up in the morning feeling refreshed. I don't mean to say you wake up in the morning like Barbie from the Barbie movie, like, good morning, we're going to do this, but you should feel refreshed. You should not have a headache. You should not feel groggy. And then even we're starting to see some links to mental disorders. So I know I just gabbed at you. Holy cats, Lauren. I just threw a bunch of information at everybody. But I wanted to kind of go through and just kind of share, these are things, right? That as a hygienist, we can see, we can screen for. So I don't know about you, Lauren. I don't know about you, Brittny, but a lot of these are things that we're already looking for that we could maybe just include in our head and neck exam screening form. A lot of these are things that maybe we could add. Like, we ask for patient report of things like, do you have sensitive teeth, or would you like whiter teeth, or whatever. There's always that sheet that we have. Maybe, hygienist, you propose to your doctor, hey, would it be all right if I added some questions like, do you experience, poor sleeping patterns, or do you get really sleepy throughout the day, or how much caffeine do you drink? Very simple, basic questions. This does not need to be a heavy lift. This does not need to be something where you completely change everything you're doing. I mean, it would be great if we did do that. It would be real great if we focused first and foremost on something that, Lauren, you mentioned earlier, is life-saving for patients. And as somebody who lost their mother to an airway obstructive disorder, respectfully, you are absolutely correct. This is life-saving for our patients. So it'd be amazing if my mom's hygienist focused more on that life-saving thing that my mom needed instead of making sure that her bridge was clean. So absolutely. I think we have an opportunity to really look at a lot of these things. It doesn't need to be a total game changer. It would be perfect if it was. But if we can do just a few small things, if you take just one small pearl from tonight and you integrate that into your clinical practice, it will completely change the way you look at your patients.
Absolutely. And even in the 8-step oral cancer screening, you are doing an airway screening. You already are. That's right. You just don't have your airway goggles on. So you want to, it's the narrow arches, it's the enlarged tonsils, it's the soft palate, it's the tethered tissues of the tongue tie, it's the scalloped tongue. You're seeing it already. So just have different eyes. Put on those airway goggles, take a look at that. And if you see something,
say something, right? That's what they say at the airport. Right. If you see something, say something.
Right, exactly.
Yes. So I wanted to just offer this really fast. This is a QR code. So I have a 12-module series that is designed for dental hygienists. And it's designed, if you have a curiosity about this and you want to dive into this more, look at how medical history plays a role, vital signs, the head and neck exam, tethered oral tissues. If you want to dive into this more and help advocate for airway in your practice, I've got a 12-module series, but if you scan this QR code, it will take you to module 1, which I'm giving away for free, just so that you can see what it's like and interact with it. And it's important for me that you know that a portion of the proceeds of this airway program, this 12-module airway program, is donated back to the State of Wisconsin Organ and Tissue Donation Foundation in memory of my mom, who was an organ donor. And 5 people are alive today and can see because of her gifts of organ donation. So we want to continue this legacy. I don't want my mother's death to be one that is rooted in darkness, but rather an opportunity to help make sure that other patients don't suffer.
Well, thank you for all you're doing. I hope you guys take advantage of this, because you can't learn too much, and you can learn so many things from so many different people and those key takeaways. So I know this may be new to some people, this may be reviewed to some people, but a lot of the questions were, we find something, then what? Who do we have the dentist refer to? So I have a feeling, Katrina, that's in your module. I would assume that, but have a talk with the dentist, and because the airway screening is important, and the ADA is calling upon us to do this as dental professionals. So it's something that you should come up with, and have a huddle and really incorporate this. There are tools, there are screening forms. I know, Brittny, you have your forms as well. So we can even send some in the follow-up emails, but maybe that's a whole other conversation. Well, we'll go through, the screening forms one by one, but we're happy to help. And I know we can't do it in 5 minutes this evening, but we have to start somewhere. And I'm glad we actually focused on the hygienist tonight. It's been a while, right, Brittny? I think that was one of our first conversations that's archived if you wanted to listen to that. So just a quick question, because I wanted to cover some of these that were asked live. Can you explain the best part of the neck to measure? I just want to make sure we got our questions answered.
Yeah, that's a tricky one. That's a tricky one, because depending on if you've got a patient that has a giant Adam's apple, and or you're trying to get kind of around the thyroid and the cartilage of the thyroid, that's going to be a bit tricky for the patient. They typically say if you, I'm not going to say you remove the Adam's apple, but if you don't use the Adam's apple as your point of contact, they want you to find the largest component width-wise of the patient. So typically you're going to find that as you get a little bit lower toward your traps up here, that it will be a slightly bit wider than it is as you come up here toward the mandible. So typically lower on the neck is where you want to make sure that you're capturing that circumference. But again, you want to be careful with an Adam's apple.
Wonderful. Thank you. Are there any other questions? Because there are some questions about becoming a myofunctional therapist, a little bit about myofunctional therapy. Brittny, maybe you could just kind of go an overview. I'll share some of our upcoming things of what's going on and the raffle, but maybe for those who haven't heard, what myofunctional therapy is and why you became one, like your elevator pitch view, your high level view.
Yeah, so I mean, the easiest way to explain myofunctional therapy, so I always like to give 2 explanations. One is the clinical way, right? So it's neuromuscular re-education of the oral facial complex. Now, when you explain that to a patient, they're going to be like, well, what? So you can relate it to, think of us like a personal trainer for the muscles below the eyes and above the shoulders. You'll hear some people relate it to, it's like physical therapy for your mouth muscles. Now, that neuromuscular component is so important, because people want to know, like, are these exercises that I'm going to have to do for the rest of my life? And the answer is no, because of that neuromuscular feedback. So we're carving new neural pathways between the brain and the muscles that are making for these lasting patterns and new habits. It is a very exercise-based program. We do a lot of behavior modification techniques, breathing re-education. I got into it because I think there was something more. I'm always wanting something more. That's just really my personality. I read about myofunctional therapy in an RDH magazine. The article was actually written by Joy Moeller, who was my first mentor. And I just knew I had to know what this was, because I never heard the term. So for those of you that are like literally hearing myofunctional therapy for the first time tonight, that is okay, because we don't learn this stuff in school. And there's always those patients in your chair that you're like, okay, something's not making sense here. And I always bring up this one specific patient because I can't remember his entire name, but I can literally see his mouth, okay? And he would constantly call the office and he was breaking crown after crown after crown. And it was like a running joke in our practice. Like, what did Mr. So-and-so chew on this time? And it's like, I'm picturing his mouth. I'm seeing the attrition. I'm seeing the wear facets. I'm seeing the neck circumference. I'm seeing the massive tongue, the scallop tongue. And nobody once asked this man how he breathes, how he sleeps, his medical history. He had all the symptoms, but I didn't know any of that then, right? I know it now. And that's why like this information, what Katrina just delivered is so empowering to us as hygienists, because we're already saving lives, but we have the ability to save lives even further. And so I think just what got me into it is my passion for learning and wanting to just help my patients in new ways. So yeah, I'm super excited. If anybody has any more like specific questions about myo.
All right. Well, we have so many conversations that we never have enough time.
Well, we have one next week, actually, a myo Q&A.
Yes, we do have a myo Q&A next week. So remind me, is that just for our graduates or?
No, I think it's open. I'm fairly certain it's
okay. You're keeping me on my toes, Brittny. All right, and so shall it be. So there we go. So I'm excited just to share a little bit of information about the courses, and then we can do that raffle to see. I just want to make sure everyone can see my screen, and we'll just do this real quick because I wanted to make sure we had enough time to get the presentation in. But are you seeing the full screen? Because it seems like I'm having full screen. Okay, wonderful. So so this is the introductory course. This is what we're going to be giving away. So we're really excited to share that. Brittny, why don't you just give us a quick overview of the Intro to Myo course and who that would be for?
Yeah, so the introductory course is for anybody just getting started in myofunctional therapy. We do, so the next cohort is going to begin on June 4th. Upon registering, you do receive about 9.5 hours of pre-learned content. And then starting on the release date of the course, which is June 4th, every week for 8 weeks, so it's an 8-week course, a new lecture is released. And then we meet that following Monday for a virtual live Q&A where we really just get even deeper in what we discussed in that lecture. The Q&As are my absolute favorite. People come with questions that maybe you didn't even think to ask, and then it's just so fun. We always end up going over the hour too. And then we do also have our business course. I don't know if that was going to be the next one.
Yeah, that's on there. I do want to just tell her that we have a lot of support with the Myo course. You really put your heart and soul into this, whether you have the Facebook group, the WhatsApp chat, the monthly case review, and your in-office shadowing opportunities. So there is lots of support after that Brittny does provide, and as well as that in-office shadowing experience if you'd like to have that. And then we also have job placement, so you can have an immediate ROI. Brittny, why don't you tell us a little bit about the School of Alumni, the paid tooth pillow internship?
Yeah, so super exciting. You get to come on board as a myofunctional therapy intern, and you are mentored by myself or Laura Eckhart, who's the other co-director of the myofunctional therapy program at Tooth Pillow. So I wish I had this because you are provided everything you need to get started, but it's always nice to have your hand held a little bit. So for your first 10 patients, you're in this internship where you are pretty much going through treatment planning, assessment, all under the mentorship and guidance of a very seasoned myofunctional therapist, and all while getting paid, right? So if you want to know more of the logistics of it, it is a sliding scale, but again, something that I wish I had. Most internships you're not getting paid for, so the fact that you are getting paid, it's like a 2-for-1, in my personal opinion. And then our myofunctional therapy courses, they do allow you to then go on to that next level and get your certification with the IAOM to receive your COM, which is your Certified Oral Facial Myologist certification.
Great, thank you. And the reviews are really fabulous, so thank you so much. We're doing a flash sale until like May 14th. Does that say? Yeah, till midnight. So Myo Flash 500. So that's why it's a flash sale. So if you're interested and you need that final sign, this is your sign to take advantage of that. So please write down that code Myo Flash 500 if you wanted to enroll in that. And then the business course is for myofunctional therapists who are already practicing. Okay. And the mini Myo, want to talk about that a little bit?
Yeah, so mini myo is treating more that 2, 3, 4-year-old age range. It's not going to be your traditional myofunctional therapy setting. A lot of patients, whether you're in pediatric practice or even if you're in your own private practice, a lot of people are very nervous to see this age group, and it really is a lot of fun. We just have to think a little bit different and get creative. They keep us on our toes 24/7. So just really giving you the strategies to be able to treat this population effectively.
Great. And then we also have your mastering tongue tie readiness. This is a really popular one. Tell us a little bit about that.
Yeah. So one of the biggest questions that I always get is, how do I know when a patient is ready to have their tongue tie released? Or how do I know if we got them to a point where their function is suffice that we no longer recommend the actual tongue tie? So really you're learning my 10-step protocol of getting that patient ready to ensure that they are going to have a successful outcome, how to do that preoperative management, that active wound management, and how to get back into the postoperative care to really restore proper function. We go through case studies. You'll see some live examples. It's really a great course.
Great. And we have our pediatric mini residencies with Dr. Ben Moralia. That's basically our entry level, and this is for doctors. So hygienists, if you want your doctors on board, call to go over our courses and maybe map out a pathway that fits your objectives, whether you're a beginner or seasoned. We're here for you as a resource. And I'm just showing you some of these courses because you may not be aware of them, but this sleep apnea and screening course is an amazing course. Dr. Dave McCarty, he's an MD, he's a board certified sleep physician, and he basically unpacks the complexities of sleep apnea. So it comes home, so you're able to have these conversations and empower your patients who do have struggling with sleep apnea, and so many are. I think once you now see the signs and start probing, I think you'll be surprised how many people are on CPAP. And I hope everyone, and Katrina, I hope you can join us too at Airway Palooza. That's going to be October 17th and 18th in Fort Lauderdale. It's all the experts under one roof. It's 2 days of fellowship and learning and fun and just real support, basically for taking the road less traveled. So we do hope you can see our lineup is quite sensational, and we're really excited. We're just about halfway sold out already, so that's really excited. So we're going to have another sellout. It's sold out for the last 2 years. So don't delay, save your spot. We do have payment plans as well, so please feel free to reach out. And we are offering another free masterclass because, as I promised, you guys show up, we will keep showing up as well. So we're doing this, we're focused on pediatric airway health. So we're going to unite. It's going to be Dr. Ben Moralia, Dr. Bill Arnold, who is a pediatric dentist, and Dr. Janelle Crichton, who's an orthodontist. So I kind of want to get the 3 specialties all together. So if you want to share this with your doctors, if your doctors aren't joining you, hygienists, this is a great masterclass. So a lot of call to action, what can be done, why it should be done, and kind of once you know, now you have no excuse. You can't not know. So it's a great part of our airway health movement. So it's a free course. So please register for that. It's basically airwayhealthsolutions.com/register. And I think we're ready for our raffle. If I can get to the next slide. Let's see. Yeah, so I'm going to stop sharing. But before I do that, I'll just have the anticipation. I did want to share my screening protocol, but maybe let me do that real quick because it's a snapshot, and I think that it will help a lot of the questions we had tonight. So I'm just going to go through this real quick. Let me just show you this one thing. I'll present this one guy. Hold on. I did want to get to this. Hold on one second. I think this will be very helpful for everyone to leave with something tangible they can walk away with and start screening tomorrow. Okay, here you go. Here's our airway screening form. I think that it'll help start those conversations. So please feel free to copy that QR code. And then maybe we'll do another airway screening where I can kind of go through this all one by one as well. Again, you can't learn too much. So learn from everybody. You'll have different tools and different takeaways. So please feel free to use that resource. I'll leave that up for a minute. Okay, so now we're going to do our raffle. So Jay, let's do our raffle. Let's see whose fate we're going to change tonight by maybe becoming a myofunctional therapist. This is so exciting. Let's see. I wish there was like music, like the. Okay, Deneen Mans. Let's see. Is Deneen with us? You have to be in it to win it. So let me just check. All the way to, let me go all the way up to D. Hold on. Wait. A lot of people. We had 800 registrants today, so kudos to you guys. Okay, Deneen, yes. Congratulations. Thank you so much. Okay, let's stop the share. Katrina, I can't thank you enough. Thank you so much for taking your time today. This is all volunteer time, and thank you for the work you do. You don't know the lives you changed just by these touch points, and it was really a pleasure to hear your story, and so inspired by you. Love hygienists who go to the next level and get to the root cause. So I think we're kins. There's a kinship here that I really enjoy. And Brittny, thank you so much for all you do and bringing this to the forefront. And it's amazing, people, what you can do to change lives. One person can make a difference, and maybe that's you this evening. So thanks, everyone. Until next time, have a great night.